Hello, and welcome to the American Medical Association's Healthy Diet and Dietary Patterns webinar series. This is the third webinar in a four-part series that's exploring what constitutes a healthy diet, the impact of dietary patterns on overall health, and how to talk with patients about their dietary choices. Today's session will focus on protein. I'm Dr. Bobby Mukamala, President of the American Medical Association, and I'm an otolaryngologist in private practice here in Flint, Michigan, and I'm also certified in lifestyle medicine. Before we begin, I want to thank you for the questions submitted during registration. You can also join the discussion and submit questions at any point during the webinar by submitting questions to the Q&A. We're going to get as many questions as we can answered during our discussion. Dietary protein is an important and essential nutrient for many bodily functions, including building and repairing muscle tissue, supporting our immune system, and metabolic function. There's a lot of current discussion and hype about protein. You may have even noticed while walking through the aisle of a grocery store that many products are being advertised as having high protein content. Many patients are curious about how much protein they should be eating and what to consider when choosing from different protein sources in their diet. In today's discussion, we're going to look at how a person's protein needs change over their lifetime and how physicians can best talk with their patients about this topic. Joining us today are three outstanding panelists, each of whom bring a unique perspective to this conversation. After their presentations, we'll move into Q&A session to answer your questions. First, I'd like to welcome Dr. Donald Layman. Dr. Layman is a professor emeritus in the Department of Food Science and Human Nutrition at the University of Illinois at Urbana-Champaign. He's served there for over 30 years as professor of nutrition. Dr. Layman is internationally recognized for his research on dietary protein and amino acids, focusing on muscle development, metabolic regulation, and the role of diet in managing obesity, diabetes, and cardiovascular disease. With over 120 peer-reviewed publications, his work has significantly advanced the understanding of nutrition's impact on health. Next, we'll hear from Dr. Heather Leidy. Dr. Leidy is currently a professor at the University of Texas at Austin. She has a joint appointment in the Department of Nutritional Sciences and the Department of Pediatrics through the Dell Medical School. She has served as the director of the research interest groups through the American Society of Nutrition and as a member of the 2020 Dietary Guidelines Advisory Committee. As a nutritional physiologist, Dr. Leidy examines the effects of dietary protein quantity, quality, and timing of consumption on the metabolic, hormonal, and neural signals that promotes satiety, healthy eating behavior, and weight management across the lifespan. Dr. Shirley Kalwaney will be our final speaker. Dr. Kalwaney is a board-certified internal medicine doctor and lifestyle medicine physician. She's the Director of Graduate Medical Education and Nutrition Medical Education at Innova Health System and co-founder and co-director of the Academy of Distinguished Medical Educators program. Dr. Kalwaney speaks locally and nationally on nutrition, diet, and culinary medicine for physician trainees and patient health organizations. She also serves on nutrition advisory boards and working groups, including those of the American Medical Women's Association and the American College of Lifestyle Medicine Health Systems Council. The full bios for all our speakers are available on the event page. We're very excited to have all of you here with us today. So let's get started. First, we'll hear from Dr. Layman. Dr. Layman, it's all yours.
Thank you, Dr. McCauley, and thanks to the AMA for the invitation. So my challenge or request was to look at dietary protein needs for adult health. I got first slide. When I think about it, I think it's important to address some myths or misconceptions that kind of frame the question. One is that protein is more important for children than adults. A second is that the recommended dietary allowance, the RDA, represents a protein requirement. And the third is that consuming protein above the RDA is just wasted and it goes to fat. Next slide. I think we've all seen these aging curves that could represent either bone health or muscle health. And we know that there's an early phase of growth that goes up to 30, 35, maybe into 40. And then we get into an aging curve. And the question in the aging curve is, what trajectory are you on? Are you on a steep curve that leads to disabilities and loss of daily function, or are you on a more gradual, blunted curve for lifelong health? As we look at those curves, it's important to think about protein needs during that. We think about children and growth, and it's important to recognize that growth is actually a very small amount. If you look at an 18-year period, the growth per day is probably less than 2 grams of protein over the 18-year period. So a child might be eating 50 grams or 75 grams of protein per day, but they're only gaining 2. Likewise, during the aging process, it's a very slow change. The change over time is probably less than 1/10 of a gram per day. Sarcopenia, we recognize, is only about 5% change per decade. But the real way to look at this is that if we look at a 16-year-old or a 65-year-old, if I could have the next slide, the daily protein turnover is almost 300 grams per day, whether you're 16 or 65. Every protein in the body is under a continuous turnover process. And we're turning that over to about 300 grams per day. If you figure that out, that means we're replacing the equivalent of every protein in the body 4 times every year. And that really becomes the issue of aging. How well do we do that? One of the things that we discovered in the uh, early 2000s is that this transition as we go into aging, we knew that there are declines in the ability to produce proteins. We know that there are changes in DNA and RNA, the transcription level, there are changes in messenger RNA, and there are changes at the ribosome level. But what was discovered in the early 2000s is that if we change the amount or the quality of the protein, and also changing in exercise, we could blunt this curve. And so what we now know is that the amount of protein, if you look at the 16 or 25-year-old, we can stimulate muscle protein synthesis with about 15 grams of high quality protein. If you do the same thing in an older adult, they basically will have almost no effect. But what was discovered is if we increase that protein to about 30 grams, we can get about the same effect as in the younger individual. So what we now recognize is there's a change in the efficiency of protein use as we get older, but there's actually still the capacity to continue. Next slide. So the efficiency is changing. There you go. As far as looking at the RDA, what we know is that in 2005, the Institute of Medicine of the National Academy of Sciences established what are called the dietary reference intakes for every nutrient, whether we're talking about vitamin C or vitamin D. We basically have what's considered a safe range of intake, going from a deficiency up to some upper limit or toxicity level. For vitamin C, we might think of that as 60 milligrams prevents scurvy, but people will routinely take higher doses, maybe 500 or 1,000 or even 5,000 milligrams for immune response. So we know that the minimum RDA is not the same as an optimum for health. For protein, the same is true. The RDA, recommended dietary allowance, is set at 0.8 grams per kg. And again, that's the minimum to prevent a tangible deficiency. Unfortunately, for protein, we don't have really a very clear deficiency. Right now, what we're using is nitrogen balance. Unfortunately, there's no clear relationship of nitrogen balance to health. It doesn't relate to obesity or diabetes or heart disease or cancer, but it's sort of a long-standing definition, really derived from growth, use of growth in animals back around 1900. So that is the bottom. Next slide. As we look at what people actually need, what we have recognized, and one of the questions I always get is, well, how much protein do I actually need? Which sort of implies that everybody has a requirement. But it's important to recognize that the need for each individual relates to their age, relates to their physical activity, and it relates to their body composition. Protein is specifically related to lean body mass. And finally, to the protein quality. What kinds of protein? Are you using high quality protein or lower quality? So these factors, these four factors all determine what an individual may actually need. Next slide. So if we look at that range again, a lot of people, the range is actually quite large, zero point 0.8 grams. We don't have a lot of data at the upper limit, at the high end, but there's about 7 studies, and they're all in pretty good agreement that there's a safe range at least up to 3 grams per kg, which is a pretty enormous safe range from zero point 0.8 grams up to 3 grams per kg. Currently, the average intake in the United States is about 1.1 to 1.2 grams per kg. So we're at the low end of the safe range defined by the DRIs. Next slide. People always ask about, well, what's the safe range or what's the risk of higher protein intakes? Well, we have a lot of data from athletes. Most fitness people have fairly high intakes, around 2.5 grams per kg. So we have a lot of information up at the high end. Next slide. Recently, the newest dietary guidelines established a dietary goal range of between 1.2 and 1.6. People responded to that by saying, well, it's double the RDA, which it really isn't. If we think about the next slide, the average intake in the United States, again, is around 1.1 to 1.2. So thinking of that as a bell-shaped curve, about half the individuals are already in that goal range, but about half the individuals in the United States are not. And what's important to recognize about that bell-shaped curve, it's not a homogeneous population. It tends to be more men at the higher end, which are in the green range, and more women at the lower end. In fact, we know that from the Healthy Eating Index that about 75% of women are actually not meeting the recommended amounts already defined by the dietary guidelines. And even more, if you look at the NHANES data, the national survey, about 20% of women over 60 and about 20% between 18 and 22 are actually below the RDA, which you can see in the far left-hand side of the curve. And so when one looks at these guidelines, one looks at these goals, it's to emphasize to people who are not meeting those goals that there's a risk. We've had a discussion, a narrative for the last few years that people need more plant-based diets. We know that plant-based diets reduce the quantity and quality of protein in the diet. And it's important to think about who's listening to those comments. Are the men that are in the higher range, or is it the women who are already in the lower range? So I think that's important. Next slide. One of the other comments I continuously hear is that protein above the RDA is just getting wasted. This is a bit of a complicated slide, but I want to take you through it because it's important to think about. This is actually a slide, an old slide actually from 1972, and it's what's referred to as direct oxidation. And it's from a specific essential amino acid lysine as opposed to protein, but the graph is the same. What you can see on the bottom is it's an increasing amount of dietary protein or lysine. And on the vertical axis, what you see is the oxidation. As you can see, as it goes to the right, we're increasing the amount from 50 to 100, and the line stays pretty flat, suggesting you're using it very efficiently. Once you get to 100, then there's basically a break in the curve. You get about a 45-degree angle, suggesting that as you eat more, it's getting oxidized. Next slide. But if you look at that a little closer, what you can see is the change is going from 100 to 150, a 50 milligram increase in intake. But on the y-axis, oxidation is only going from about 4 to 14. So only about 10 milligrams is getting recovered. So the idea that we're wasting everything, the fact is we're only recovering less than 20% of the protein you're eating. And so the question is, where's the rest going? Next slide. What we now know about amino acids is they have multiple roles. All amino acids have a shared role in what we call protein synthesis, and that's what we usually think of, and that's probably what nitrogen balance best reflects. But every amino acid has an additional metabolic rule, and that relates to all sorts of things from glycemic regulations to neurotransmitters and all sorts of other metabolism. Next slide. So this is just a list of the 9 essential amino acids and some of their metabolic roles beyond protein synthesis. Next slide. If I just go through and pick out a couple of these, I don't have time for a lot. Leucine is an amino acid I work a lot with, and we know that in young individuals that growth is predominantly controlled by hormones, growth hormone, IGF-1, et cetera. But as we get older, the protein turnover in muscle and in bone is controlled by diet quality and predominantly the essential amino acids. And it turns out one of the most important one is leucine, which triggers an enzyme complex known as mTOR. Leucine is also the precursor for the non-essential amino acid glutamine, which is a primary fuel of the gut enterocytes, and also the precursor for arginine, which is considered a non-essential amino acid. Next slide. Another of the amino acids, one of the sulfur amino acids, is methionine. It has multiple roles in RNA and DNA synthesis. It's also a primary precursor for the primary antioxidants in the body, glutathione and taurine. Next slide. And the last one, just for diversity, is threonine. 75% of threonine that comes in the diet is extracted by the gut enterocytes for production of mucin, the protective layer in the gut. So the thickness of that mucin layer is directly related to the threonine in the diet. On a low protein diet, that mucin layer is thinner. Higher protein diet is thicker. So basically, we know there are all of these different metabolic aspects. And all of these aspects require oxidation. So as we get that break point where the amino acid metabolism is reflecting a change in partitioning, we're going from the initial requirement, which is for protein synthesis, to all of these other metabolic requirements that all relate to the concentration in the cell. These are all what we call first order kinetics. And so if the values do not go up in the cell, we basically down regulate these. Next slide. Just to illustrate one of those, the methionine pathway, for example, as it's metabolized going from methionine to homocysteine, we have what's called the one carbon metabolism, which is basically essential for DNA and RNA synthesis. From homocysteine, we go to the non-essential amino acid cysteine, and from that, they're the direct precursor to glutathione and taurine, the antioxidants. Next slide. If we look at the sulfur amino acids, methionine and cysteine in young adults, the requirement is set at 19 milligrams per kilogram body weight, which is basically nitrogen balance. But if we think about the requirement to optimize glutathione, what we find is that in older adults, in a 65-year-old, the level of glutathione will drop by about 50%. But we can actually make it equivalent to the 25-year-old by increasing the amount of methionine or cysteine in the diet, almost doubling the requirement. Last slide. So if we think about adult protein needs, it's very important to recognize that as we age, the efficiency of protein use goes down. We can buffer against that by, next slide, by adding in more essential amino acids, increasing the quality, and also the synergistic effect with exercise. Those are the key points. One of the problems we have then with the plant-based narrative is it will drive down both the essential amino acid and the amount of protein in the diet. So one has to be very careful with that as to who's going to be affected, who's listening to that narrative, and what's the ultimate outcome going to be. We recognize the importance of fiber, but that's really an issue that the carbohydrates we're eating in the diet are mostly refined grains. We hear an argument about saturated fat, but it's important to recognize that 35% of the saturated fat in the American diet now comes from ultra-processed foods and hydrogenated vegetable oils. So it's important that we think about protein as an isolated issue and what we're trying to achieve with essential amino acids. So thank you, and Dr. McCarthy.
Thanks, Dr. Layman, for that informative presentation. It made me feel like I was looking at a chalkboard in the last century. I walked down chemistry lane. All right, Dr. Leidy, microphone's all yours.
All right, thanks so much. So I'm going to switch gears a little bit, really thinking about protein. Obviously, we think about protein as a nutrient, and I think Dr. Lim did a fantastic job looking at it from an amino acid standpoint. When we think about dietary patterns, a lot of it then goes into protein as a food. And so I'm going to discuss that in the confines of looking at children and adolescents. And the title here is The Perfect Storm. Many of you, if you work with those types of patients, it can be a challenge all around. And so we can keep going. I just wanted to acknowledge my disclosures. And then if you go to the next slide, when we think about this perfect storm, I mean, most of us in children and adolescents, we know that there's an extensive and sustained growth and neural cognitive development that occurs. And so, right from the get-go, their needs are higher. And so if we just animate this slide, when you look at the increased nutrient requirements that exist, protein is one of those. I don't think Don mentioned it, but with children and adolescents, that range, even for the RDA, is higher. It's anywhere between 0.85 to 0.95. And again, that's the minimum to prevent protein deficiency, not really about that optimization that Dr. Layman had talked about. And so along those lines, you can see that there's a number of other nutrients that are also that have a higher requirement with aging all around. And these are vital to all of those processes. The problem is so the reason I really think about this in the perfect storm is because we have this really important rapid growth phase, both with physical and cognitive and even social. So the requirements are higher, but then we also know that there's significant reduction in nutrient adequacy. So all the ones that you can see on the left that are higher in this, and when I say higher, it's higher across all life stages with teens and adolescents. And so when you look at inadequacy, all of those are very similar. Energy, they are generally getting enough energy, but it's all of those other micronutrients and macronutrients where that's a problem. And then the black ones there, magnesium, potassium, fiber, B6, and choline, you can also see are additionally under-consumed. And for me, the question is, well, how drastic or how big of a deficiency or inadequacy do we have? So if you go to the next slide, this is just some of that NHANES data from what we eat in America, looking at teens consuming less than the estimated average requirement. And Dr. Layman didn't even mention that. We talk about RDA. The EAR is 50% of the population meeting needs. And so those requirements are in essence lower. Most of the time, what we think about is anything greater than 10%, where you have 10% of the population or more that's not meeting that, it's a significant concern. And when we look at, this is in older teens, 14 to 18 years, females and males, I just drew a line there at that 10%, and you can see these vital nutrients. I mean, the essential nutrients, protein, iron, calcium, zinc, across the boards. Most of those, particularly in females, are well below that 10, or higher than 10%, right? We can see that, particularly looking at calcium, vitamin D, magnesium, and potassium is a significant problem. And when we think about protein, generally adolescent males are close to meeting the EAR. Again, that's well below the RDA, and then not at that optimized protein or the healthy range. You can see with female teens, very low. And so again, this is really getting us thinking, well, what are strategies? What can we do about that? So if you go to the next slide, that's the nutrient perspective. And then when you also look at the data based on food groups, right? So again, these are coming from what we eat in America, and then overlaying that with the guidelines in terms of servings per day. The blue bars are what is recommended, and then males and females down below are the orange circles. And so obviously this isn't anything new, just more updated data that suggests that, right, in adolescents, not meeting vegetable, fruit, whole grain, or dairy consumption, although I will comment in males and teen males, they are close to meeting those serving recommendations, but females are very, very low. If you go to the next slide, this is looking at it from a protein food perspective. So looking at all those, whether it's meat, poultry, legumes, seafood, eggs, nuts, and seeds, again, very low consumption across the boards. Nuts and seeds are really the only ones that males and females are consuming within those serving ranges. But we also have that quality issue in terms of the protein and the essential amino acids in those. And so again, we can see here across the boards, whether it's protein as a nutrient or protein as food groups, where they're not meeting the recommendations. So we go to the next slide. And so we look at that, and then you start looking at the types of foods. And so what's really happening in teenagers specifically, but we also see this in kids as well, is they're under consuming nutrient dense foods, right? It's a lot of those foods that are fresh, non-processed, that are lacking in their diet, and so they're not getting those micronutrients, not getting their protein as well, and they're over consuming an increase in energy dense foods. And so that's in essence creates the problem that we have with nutrient adequacy. And we know that nutrient adequacy is directly related to health and well-being. To add another level of complexity with our storms, if we activate these, I just wanted to remember you guys are neck deep in this, but when we think about some of these other factors, if we can go to the next activation, there's obesity, pretty high prevalence in adolescents and children at 35%. You also have chronic conditions that typically go along with that, whether it's diabetes or hypertension. Some other things I think that are also really important is poor mental health, and that's a vital part of adolescence. We know that about 40% of teenagers struggle with that. If we keep going further, we also have, it's kind of interesting, right? Because when you think about teenagers, half of the population have higher physical demands than generally in adulthood, those that are participating in sports that actually need more of a lot of these essential nutrients. But then you also have inactivity and sedentary lifestyle. So that also adds another factor. And then I think there's one more, and that's that poor sleep health, right? We know about 75% are not getting the amount of recommended sleep and the quality of the sleep. And so all this creates this behavioral lifestyle and health problem that we have. And then you overlay that with poor nutrition, it's a problem, right? And so what is the value of protein in the diet, and how can some of these things be alleviated? And that's what I'm going to end with for the rest of the talk today. So if you go to the next slide, I wanted just to show you the value of protein-rich foods in the diet. And so this is some NHANES data in teens looking at protein-rich animal source foods and nutrient adequacy. If you're curious why there aren't plant source foods here, there isn't any data yet that's available. I would suspect a lot of it's because most teens don't consume, they consume very little legumes and nuts and seeds. And so what I'm presenting is the data that actually is published. But there's a lot of value in looking at protein-rich animal source foods. And so what you see here, these are the articles that came out from NHANES comparing adolescents and children, those that consume, in this case, if we look at eggs, those that consume eggs versus those that don't. Same thing with dairy, those that are not meeting dairy needs versus those that are, and then beef and pork. And so the circles are just showing you the micronutrients and the protein and fiber differences in individuals who consume eggs versus those that don't. All right. And the percentages that you see, that's what you typically get with one serving of these foods. And so when you're looking at, you can see the protein differences here, but then also a lot of those micronutrients. And I bring this up really to hit home the fact that protein-rich foods like animal source foods can provide protein, obviously, but they do provide a lot of those micronutrients that are public health concern in this population. We see the same thing with dairy, when dairy's at the recommended amounts. Same thing with beef and pork, when they're included as part of a healthy diet, you do get an increase in micronutrients and nutrient adequacy. And then one more point on this slide that I think is interesting is when you look at beef and pork, but I'll just highlight here with beef, you can see the bubbles in the orange and what beef can provide and what the differences were if they were in the diet or not. But you can also see that folate and calcium were also higher in those that consume beef versus those that don't. I'm sure you're well aware that beef has very little, if any, folate or calcium. And so what's going on here? And a lot of that is the food pairings. Same thing with pork, you see with calcium. So a lot of these animal source foods are paired with foods that can also increase diet quality. All right, I think that sometimes gets overlooked. If we go to the next slide, this is just kind of showing the magnitude of differences from the beef study that I just presented. So again, NHANES data in adolescent girls, looking at the differences between beef versus non-beef consumers. And again, just wanted to highlight that because when you take a single protein food and you incorporate it as part of a diet, a lot of those inadequacies that are outside of protein can be reduced with single protein-rich foods. Right, so that's kind of what that's illustrating. And then if we activate this next piece, I do want to highlight, though, that, I mean, the data that we have right now that's published is all on animal source foods. There is fundamentally a synergistic effect when proteins are mixed and matched with plant and animal source foods. And so there's a systematic review that I wanted to show here as a concept that when you look at vegan, vegetarian, and omnivorous diets, obviously with vegan and vegetarian, they are inadequate in many things that you find that are rich in animal source foods, but then they also are high in other things like fiber. You can see that with folate. Those are, I would say, one of the two bigger things. And so when you're mixing and matching your protein-rich foods, you can get a healthy dietary pattern in doing so. The challenge is it goes back to essential amino acids and those other micronutrients that go along with protein. And so the second bullet there, I think, is a really important part. There have been a number of studies that actually look at what is the ratio of animal to plant proteins. And I would say, what we now know when we think about 1.2 to 1.6, which is that healthy range of protein, it does take about a 3-to-1 ratio, 3 per animal to 1 plant source to get you at the quantities that are needed. And I highlight the bean circle here just to illustrate that, beans and legumes are really a high quality protein source, even though the protein there is though a smaller percentage, but you do get, fiber and folate with that. So again, mixing and matching, but also being mindful of including that animal source foods in the diet. So if we go to the next one, I just want to kind of go full circle and think about the translation piece. And so I've spent the last 15 to 20 years really looking at high protein breakfast for weight management. So this is really where those health outcomes come in. And just due to time, I'm not going to cover too much, but I will say, one of the things when we know the value of protein and protein rich foods, there's a lot of value with having that in the morning meal. And that's what we've looked at in teenagers. And so done a number, whether it's acute or long-term trials, generally about 24 to 30 grams of protein. It's a mix of protein, but they generally are emphasizing animal source foods. And you can see the bullets on the top there. These are really the benefits that we see in terms of satiety, food cravings, reduction in food cravings. Usually snacking behavior is lower when a higher protein breakfast is consumed. And then we do see some benefits with weight management. So if we activate this, just wanted to show a couple data points on this. This is looking at body composition in breakfast skipping teenagers, which is pretty high prevalent, pretty common in this population. Looking at what happens when a higher protein breakfast is consumed. And so we can see here with body composition, this is just looking at fat mass, where breakfast skippers who continue to skip breakfast actually gained body fat. And these, within most of these trials, they have, the adolescents already have overweight or obesity. So adding additional fat mass is not helpful. And so you can see there with, when they're just skipping breakfast, what happens. When we provided a higher protein breakfast, that's when you start seeing that fat mass gain can be prevented, but it's only with higher protein, not the normal protein pattern. So if you go to the next one, this is kind of looking at a mechanism in terms of, well, how is this happening? And what we found is that when teenagers actually have a higher protein, high quality breakfast, they voluntarily reduce their daily intake. And that's what you're seeing with the red bar here. It's about it's about 400 calories that they're voluntarily reducing by actually eating breakfast. So they're adding more calories, but they're reducing it. And when we did a lot of dietary assessments, it's really that unhealthy snacking on highly processed foods is what's reduced. And we pair that back with satiety. And so typically when they're having breakfast that's higher in protein, they have higher satiety, less hunger, and that's allowing them to make better food choices. And then the last one I think is just really relevant for them, when we think about metabolism, glycemic control. This is just looking at some CGM data that we have in teenagers when they're skipping breakfast versus when they're consuming a high protein breakfast. And so the black line is just showing a profile over 24 hours when individuals are skipping breakfast. And so you can see oddly some fluctuations. This is at night, it starts at night and then goes in the morning. And so it's really high in the middle of the night, and then nothing in the morning, then it rises at lunch. And then you start seeing these rises again. But when they have a high protein breakfast, you can see that all of those responses are blunted. And statistically, we do see that there's better glucose control when there's protein consumed at that breakfast meal. And so just to summarize for today, 2 main points that we have. If we can go to the next slide. We do know that adolescence is a critical life stage. We know that their diets are extremely poor. They're making poor food choices, and they have really poor diet quality. And it's really represented with protein inadequacy, as well as a lot of those micronutrients. And so some of the data really does suggest that having that high quality protein breakfast around 24 to 30 grams of protein can improve diet quality, as well as some of those health outcomes. And so with that, I'll turn it back over.
Awesome. Thanks for that great presentation, Dr. Leidy, about the younger folks among us and how they live and what would be a better way. And lastly, we're going to hear from Dr. Kalwaney. Dr. Kalwaney, it's all yours.
Thank you so much. I appreciate it. And it's wonderful to be part actually of this webinar today. So obviously my panelists have reviewed the importance of protein. And so over the next 10 minutes, I really want to provide protein guidance as a clinician and medical educator. and also in the broader context of patients that I see and our chronic disease crisis. Next slide. So let's start with chronic disease because this is where most of our protein conversations are happening in the clinical setting. So you can see here, according to the CDC, 6 out of 10 American adults have at least one chronic disease, and 4 out of 10 have 2 or more. And we are seeing obesity in 40% of our adults and 20% of our children. Half of adults have diabetes or pre-diabetes, and many of them are unaware of actually this diagnosis. And cardiovascular disease affects nearly half of all adults, with 1 death every 34 seconds. So that's pretty striking. And diet quality is a major driver for cardiometabolic risk, and protein choices are directly connected. So when I tell patients it's not just how much protein, it is what protein foods are you consuming, what are you replacing with other foods, and then within what overall dietary pattern. Next slide. So the good news is that at a population level, Americans really are not, they're really generally not protein deficient. And as a clinician, I really don't see this except in specific illnesses. And I practice in the inpatient setting, and I teach also in that setting as well. And this is the 2023 What We Eat in America database, from the NHANES National Health and Nutrition Examination Survey, and this is 2023, which shows that on average, in terms of protein intake, it's generally adequate. But we see that fiber intake remains low, and actually saturated fat actually exceeds recommended targets. So clinically, I often tell my residents that we don't really have a population-wide protein deficiency crisis. We actually have a fiber deficiency and diet quality crisis. Next slide. So let's look at what our patients are actually thinking. So in 2024, the International Food Information Council Food and Health Survey study found that 71% actually of Americans are trying to increase their protein intake, actually the highest of any nutrient here. But what's also equally striking, I think, is 64% also want to increase their fiber, and 44% are trying to limit or avoid saturated fat. So patients' instincts are pointing in the right direction. So this is our clinical opportunity during these patient visits. Next slide, please. So how do we talk about what to eat? So when a patient says to me that they want to eat more protein, we should ask, what is driving that overall goal? Is it muscle building, weight loss, healthy aging? The motivation shapes everything. We use motivational interviewing as a patient-centered approach for behavior change counseling, and eliciting a patient's own motivation is what really makes dietary change sustainable. And mostly these evidence-based nutrition informations, they really don't have that foundation. It really sticks. Next slide. Okay, so common patient scenario that I deal with and many of my residents and colleagues is that when a middle-aged patient or older adults try to consume additional proteins, they try to do it in the form of, especially in the form of protein shakes or protein bars, which can be highly processed and with additives, but they want to build muscle. That's really, and of course, that's extremely important, as already highlighted. But protein alone is not the best method. So this is just a systematic review and meta-analysis of 28 randomized control studies that examine the effect of higher versus lower protein intake on lean body mass and strength in adults over the age of 50. The finding was that without resistance training or resistance exercising, increased protein intake really didn't have a significant effect on muscle mass or strength. So protein is necessary, of course, for muscle building, but it is not a standalone intervention. And this is, I think, a powerful message to give to our patients. And of course, note that for athletes who already, I believe, are taking in so many calories anyway, so they usually meet their protein needs. But for older adults, pregnancy, and in other illnesses, which I do see a lot in the hospital, protein needs can be individualized and should be. Next slide. So now protein intake and aging is real, but it's nuanced and it's usually multifactorial. So the underlying drivers, which include depression and loneliness, highlighted here in red because it is so common, as well as others on the list, are important. So when an older patient is not needing enough protein, it's usually, the overall intake, and we should address the root cause. So we should think about social support, dental care, reducing polypharmacy. Meal delivery is very important with food as medicine programs like medically tailored meals or medically tailored groceries, or recommending even nutrient dense meals that the patient will actually eat. Next slide. So in March of 2025, Nature Medicine published a very large prospective data study from 100,000 participants, the Nurses' Health Study, which people are familiar with, and the cohort, the Health Professional Follow-Up Study. They followed for about up to 30 years, and they examined the adherence of 8 healthy dietary patterns and their association with healthy aging, which they actually defined as reaching the age of 70 and free from 11 major chronic diseases, which of course is cardiometabolic diseases and the others, including cancers. And sadly, actually, from this study, they found that only 9.3% of participants achieved that outcome at all. But every single healthy dietary pattern study did show that when you have a higher adherence to that, it was associated with a higher odds of healthy aging, and especially for the alternative healthy eating index, which is an index that the goal is to reduce chronic specific cardiometabolic diseases like type 2 diabetes and coronary artery disease. And that pattern has actually more plant proteins and also fatty fish for the omega-3 fatty acids. Next slide, please. Next slide. Thank you. Oh, sorry, again, sorry, go back. Sorry, I didn't see that. So this is the heat map related to that same paper. And really, after you can see the association, after a full multivariable adjustment between individual foods and the odds of healthy aging. So I just want to highlight that on the top left, you can see the green things that are highlighted in green, which are correlated with healthier aging. These are strongly linked, and those are foods that are, fruits, whole grains. These are whole foods. Nuts and legumes, vegetables, olive oil, yogurt, low-fat dairy, which is, consistent with many of the diets, of course, Mediterranean diet, the DASH diet that we try to prescribe. In comparison to the bottom right in red, you can see that foods that are inversely associated with healthy aging: processed meat, unprocessed, red meat, trans fat, added saturated fat, and organ meats. And so for clinicians, I think the message here is practical. So when older patients ask about protein, we should guide them towards protein sources embedded within a Mediterranean style, plant-forward type dietary pattern. Next slide. So the concept I find most clinically useful in what we call the protein package. So, protein doesn't come in isolation. It comes surrounded by other nutrients that was highlighted earlier too. And those nutrients matter enormously actually for the health outcomes. So multiple studies, large prospective studies really converge on the same conclusion, is that when we add more plant-based protein from the current consumption, we can have beneficial health effects. Next slide. The point of this slide is just really so you can see that plant foods can meet protein needs. So if people want to swap out some of the animal products, it's very doable. And these are accessible, affordable, even legumes that people should really consume more are cheap, especially if you have dry beans, then we could talk about that, but very affordable and come packaged with fiber, antioxidants, phytonutrients, which are important. So when you shift, towards some of these sources, you may lower the risk of diabetes, heart disease, some cancers, and it really does support a healthier gut microbiome as well with the fiber. Next slide, please. So I would recommend everyone read the recently updated 2026 American Heart Association scientific statement on dietary guidance, and this is to improve cardiovascular health. And the panel suggests actually shifting from meat to plant-based sources when possible, such as legumes and nuts into their diet, regularly consuming fatty fish, seafood, select low-fat dairy, and if red meat is desired, to choose lean cuts and avoid obviously the processed forms of meat and limit the portion size. And this statement also reinforces patterns rich in dietary fiber, limits cholesterol, and targets a saturated fat level of less than 10% of the total energy consumed. Next slide. Another concept I use frequently when I counsel patients is crowding out. So one of the concerns I have when we have excess protein intake, and I've seen this as well in patients, is that it can displace a variety of healthy foods, such as whole grains, fruits, vegetables, fiber, healthy fats, especially when we want people to decrease their overall calorie intake for healthy weight. So, when you have excessive protein of any sort, it's not great. And so you want to make sure that you have a good balance. And I also want to recommend or remind everyone, excuse me, that the World Health Organization classifies processed meats such as, hot dogs, bacon, sausage, deli meats as a group 1 carcinogen with the association of the strong association with colorectal cancers and others. And the American Institute for Cancer Research and the American Society of Clinical Oncology both recommend avoiding all processed meat. Next slide. So this brings me to perhaps the most important reframing for nutritional conversations is that we should not chase single superfoods, whatever the superfoods really means, or single nutrients for that matter. We should guide our patients towards dietary patterns because it's really that consistency, that compliance over long periods of time that really improves their outcomes. And if you can just for the animation, thank you. So with the examples I'm showing here, you can comfortably deliver a large amount of protein with plant proteins. Obviously, you can mix it with different things and swap for different meals. But here you can comfortably, this is something that I've prepared too, and I have recipes for about 72 grams of protein. But it's also, remember, alongside fiber, phytonutrients, and unsaturated fat. Next slide. And I want to close this section out really with a point that increasingly resonates with my patients and medical learners, especially younger ones, that the foods that are best for human health are also best for planetary health. In this study, this graph notes 15 different food groups on 2 axes. The x-axis represents relative risk of mortality, and we're related to cardiovascular disease, type 2 diabetes, for example. And then the y-axis represents the average relative environmental impact. So that's greenhouse gas emissions, that's land and fresh water use, eutrophication, acidification, all those things related to planetary health. And in this study, you can appreciate that unprocessed and processed red meat are associated with both the highest mortality risk and also the risk of the highest environmental footprint. But if you look at the vegetables a little bit lower down on the left side there, where you have vegetables, fruits, whole grains, nuts, and legumes, you can see some healthy plant proteins there. It's much lower. And in a recent food and health survey, almost a third of Americans report that they want to eat sustainably. It's important to them. So when a patient raises that environmental concern, I feel that that is a motivational window. Next slide. So I just want to highlight a couple things. So at Inova, we try to close the gap with evidence and practice through 3 parallel efforts. The first thing is, we do have a culinary medicine program, and that gives medical learners hands-on experience. And they get some background in preparing healthy plant-based or plant-forward meals. And they also, as they build also evidence-based nutrition knowledge and learn about food as medicine programs, very important for their patients, obviously for them to build those skills. We also train residents in motivational interviewing techniques specific to dietary counseling, which is very skills-based. And also residents have led multiple QI quality improvement projects related to the hospital environment, the hospital food environment specifically. And we redesigned a provider cafeteria menu that aligns actually with national heart healthy guidelines. Next slide, please. And this is my final slide. So I just want to summarize. So I want to, highlight that we should be having, when we start with these protein conversations, we should be talking about the actual motivation for the patient. Why do they want to, what does it do to, what have they, been exposed to, and how does that fit? And then pair protein advice with resistance training. I think that obviously is going to be very beneficial for strength or muscle mass, and especially with patients that are over 50. And really in the previous study with over 60, 67 or so was the majority of that group. And then in the elderly group, you have to evaluate the multifactorial reasons or causes for low intake of protein and really all the nutrients that we have to worry about, which I see a lot. And then also, consider the protein package. That's very important. You have to consider elements like fiber, phytonutrients, unsaturated fats, saturated fats, sodium processing, all those things have to, be incorporated when you decide the matrix of actually your protein that you're choosing. And above all, focus on dietary patterns. I think that we should avoid talking about single nutrients, look at, and superfoods as well, which I always get asked on, but look at dietary patterns and how do people adhere to that over long periods of time, meet them where they are with motivational interviewing, and having that continuity with the patient. That's so important. And really, the clinical goal I look at is it's not just simply about more protein, but it's really about the better protein and within a healthier diet. So thank you.
Hey, thanks, Dr. Kalwaney, and thanks to all our presenters for sharing their insights and big time expertise on protein. I'm sure there are a lot of questions that we've got here, so we're going to get to those now. We're going to start with some of the questions that we submitted, or you guys submitted before the event, and then we'll get through as many as we can in the next just under 10 minutes or so. So here's one that we got. How do various protein sources react when they're subject to high or ultra high processing of food? Does the protein, does it degrade like other nutrients in whole foods after they're processed? And anybody that wants to answer, just go ahead and jump in. We'll go through these quick.
The most obvious reaction is the Maillard reaction, where you're reacting protein with carbohydrates. So browning reactions will cause loss of essential amino acids. And in general, though, heating does not destroy protein or amino acids.
Okay. Dr. Layman, how much is too much protein? Are there symptoms that people should look for? We saw that graph, but
there really isn't any upper limit that anyone has defined. It hasn't been studied greatly. There's a lot of literature about, renal problems and the need to control nitrogen waste and things like that. But in healthy individuals, there's a lot of evidence with people consuming up to 300 grams a day or more with no adverse effects. So we don't have good data at a high end, but there's really no adverse effects that have been shown.
Okay.
I would add to that. I think with patients who are older, we have to be careful with chronic renal insufficiency.
Sure.
Having higher protein in certain populations, especially CKD, we do have a hyperfiltration problem with that can further exacerbate the problem. So you really need to know about their GFR and that. And I find that, again, I'm back to the point of, if you take too much of one nutrient, you're not going to, or type of food, protein foods, you're not going to take the others. And I see that a lot too, especially in younger patients, is that they're taking a lot of, protein supplemental foods or protein supplements specifically, and then they're, crowding out the healthier foods. And I worry about that.
Yeah, and I would just add to
seldom,
that.
yeah.
No, go ahead. Go ahead, Don.
Yeah, seldom in older individuals do you see a case where they're eating too much protein. And I think the way she expressed it's important that people who have a chronic disease, you have to take it into consideration. But the parallel is that protein does not cause the chronic disease.
Yeah, and I was just going to add, when you think about protein in the context of quantity, that healthy range of 1.2 to 1.6, the modeling that's been done, that's published, really does support that when you have 1.2 to 1.6 in that range, you're able to meet all the other, whether it's micronutrient requirements, as well as food group requirements, getting your fiber and all those other pieces in there. So the 1.2 to 1.6 is really that range that also helps with nutrient adequacy. So, beyond that, I don't think anybody would say that unless you're talking about athletes to go beyond that, there is no upper limit. But again, where is that sweet spot where you're able still to have all the other recommendations met, and that is that 1.2 to 1.6.
Thanks. Here's one that living in Flint, it's one that I get questioned a lot about now that we're doing this stuff. What are some helpful ideas about people obtaining healthy protein at an affordable cost? I know that came up in some comments already, that the things that we might think are real expensive really aren't. But any foods or resources that you could share about the affordable proteins?
Yeah, I can comment a little bit about this. That is a very important concern. So first of all, I would recommend people not use the supplemental bars and protein powders. Those are very expensive already, and I would recommend, they're usually ultra processed, and we want to get away from that. Obviously, we want to get people away from the processed meats as well. But in general, I think if we can try to get them to take more plant protein, actually legumes, whether it's beans or lentils or any of those dry products like that are very, very affordable. You can get $2 per pound for that. They're packed with fiber and also protein and all kinds of other things like iron and all the nutrients we've been talking about. And so that's very affordable. Frozen foods also get a bad rep. I always eat the edamame and peas and everything. Those are flash frozen and they tend to be they preserve their nutrient quality, and they tend to be cheap as well, especially if people are trying to eat seasonally, because you can get fresh food is expensive during different times of the year. So I tell people to do that as well. So that's what I would say.
I think when we think about cost, I think there's a theoretical diet, which was just described, which is less expensive. But then there's the reality diet. And we did a study at the University of Illinois looking at SNAP program participants. And what we found is when they go to, as Heather was talking about, higher protein breakfast from using high quality protein, what they stopped doing was expensive snacks. And what we found was in the lower socioeconomic groups, they were buying a lot of foods and snack foods at convenience stores, which are incredibly expensive, nutrient, calorie dense and nutrient poor. And so they actually save money increasing their protein intake from high quality proteins versus eating snack food. So I think we need to be really careful about what reality is versus theoretical diets.
Thanks. Now, what about some of the health conditions that require a larger intake of protein? So somebody with chronic wounds or cancer, how does your message change to folks like that?
I think that weight loss, I think that wound recovery, I think bone healing, I think all of those, we have seen the merits of higher protein, but it's not particularly out of the range that's being recommended of 1.2 to 1.6. Most of those comparisons have been the RDA versus that kind of a range. So 1.6 is far more beneficial for recovery. Again, as already been said, evidence for really high intakes, 2.5, there's really no data to particularly support that. I think some people will make choices of high protein to avoid carbohydrates. And that gets into the athletic world, that we know that the higher protein, if it's substituted for carbohydrates, can help with body composition. So some athletes will make those higher protein decisions, but we know from a metabolic standpoint, the 1.2 to 1.6 seems to cover pretty much everything.
Yeah, and I just wanted to comment too, because sometimes you hear higher protein or increased protein, and it's not about adding more protein. And I know, Shirley, you had mentioned that too. And that's not the intent. I mean, we're really close to even being within that range for many Americans anyways. I think a lot of it, and Don just talked about that, it's substitution for first and foremost of prioritizing protein and then making sure that you're reducing a lot of the refined grains and carbohydrates that are really just not necessary in the diet. In terms of our US pattern. And so I think it's something to keep in mind when we think about protein. I think prioritizing it and choosing those that have the most protein density as well as nutrient density is first and foremost, but then there's that trade-off in terms of reducing those other foods.
Yeah, I would just add to that substitution that since the original guidelines in 1980, we've seen a 35% reduction in milk consumption and an egg consumption, a 40% reduction in beef. And those saturated fats have been replaced by hydrogenated vegetable oils. So we now get 35% of the saturated fat in the American diet is coming from synthetic fats. And there's absolutely no indication that that's been a healthy change.
Got it.
I'll add too, I agree with that. So I think that we don't want people to have to replace with ultra processed food, which is, where a lot of these fats are coming from, but also from specific meat products, or animal products. But I do think that just, not sort of pushing people towards, whole grains, which is important. A huge part of our diet, a huge percentage should be healthy carbs. It shouldn't be just, obviously we don't want processed food at all. We all agree with that. So it's really about also incorporating some whole grains, and then obviously, we're not meeting anywhere close to fiber. So we're not going to get that from meat because there is no fiber in meat. So we have to also keep that in mind, is how do we balance that? And that's why the pattern is so important, instead of just focusing on the nutrients or single foods.
Yeah, I totally agree with the fiber point. We currently get 70% of the calories in the American diet come from plant-based foods, but over 80% of those have essentially no fiber in it. And so the argument that we need a more plant-based diet, I would argue that we actually need a better plant-based diet.
All right.
Yes, I agree with that. Whole food, it should be in whole form, I agree with that.
100%.
100%. Right.
All right. Well, we're getting at the time, so we're gonna wrap this up. I just want to thank everybody again, these amazing speakers, for taking the time to provide these insights on dietary protein and how we can actually have meaningful conversations with our patients on how to take healthy food seriously. We appreciate the important work that you do, and you're extremely grateful that you were able to share this expertise with us on this topic. So this is the third event in a series of webinars we're organizing on healthy diets and dietary patterns. Please mark your calendars for the last webinar in the series, which is going to be on Tuesday, June 23rd at 2 p.m. Central, 3 p.m. Eastern. That session is going to focus on preventing and managing chronic disease through diet. A link to watch past events and register for future events in the series is going to be sent to today's attendees. CME is available for today's webinar. Just make sure you're signed into your free AMA EdHub account and click on Take Quiz. So thank you again, everybody, for joining us today. We're looking forward to seeing you at our future AMA educational webinar. Thanks, everybody.
Thank you.
Thank you.